Hello, welcome to Beyond the Limits with me, Mike Forsyth.
And me, Matt Clark. We're grateful to be joined by Dr David Garley this week from the Better Sleep Clinic. And it was really great to get an expert opinion to break down some of the sleep myths and also to get some tips for better sleep.
We actually received a lovely email from a listener the other day imploring us to focus on sleep. Tellingly, it was received at 3:30 a.m. So we're very grateful to Dr. Garley for giving the people, or person at least, what they want. I was really interested to hear in particular about how tech companies are dipping into the world of sleep with wearables and sleep analysis available at the touch of a button, and whether these are in any way accurate. I hope you find it enjoyable and informative, and if all else fails, you can stick on any episode of Beyond the Limits and allow mine and Matt's dulcet and soporific tones to send you off to the land of the nod.
Welcome, David Garley. Welcome to the podcast. Where did your interest in sleep medicine come from?
So I previously worked as a respiratory registrar, so seeing lung patients. And respiratory medicine, it is really interesting. Like I really do love it, but sometimes you feel that the treatments haven't quite kept up with the diagnosis and the investigations, and you're often left wanting to do more for some patients. Often the target of treatment is to reduce the rate of decline of lung function, which is important, but sometimes you don't get that kind of air punch that you can get in other areas of medicine. But the one exception to that backdrop of respiratory medicine was working in sleep. So a lot of sleep disorders come under the respiratory team because a lot of sleep disorders relate to how you breathe when you sleep, things like sleep apnea. And actually, if you get a patient who's got really good going sleep apnea, who hasn't slept properly for what could be a decade, who is hugely fatigued, falling asleep as soon as they get home from work, some ways mimicking dementia. And actually, the diagnosis is relatively straightforward, and the treatment can be very straightforward. And sometimes it's 2 days later that you're looking at a completely different person, that it's up there with, kidney transplant in terms of a new lease of life. And I think, especially for something like sleep, which hitherto had been quite a vague concept, that it really highlights the impact that sleep can have on your health and well-being. And I was quite hooked from that point. So I've since moved from respiratory to general practice, and I see a wider range of sleep disorders. I've run my own sleep clinic, and we deal with things like insomnia and other sleep disorders. But it's a really satisfying place to work, and it kind of couples this um, really quite impactful change you can make in someone's life with this kind of still quite mysterious enigma of sleep. It's a really great place to work.
It's an area that, since we've started doing the podcast, we've actually had a lot of emails through from people saying, can you do something on sleep? It's that kind of topic that really fascinates people. And I know from my clinical practice, it's also really hard to deal with. And someone comes in and says, I can't sleep. It's really hard to address that. So really looking forward to picking your brains on this. I'm just going to take us back to start off with the history of sleep. So I think traditional teaching often talks about the importance of 8 hours sleep. But am I right in thinking this concept of uninterrupted sleep hasn't actually always been the norm? There was this concept, I believe, of biphasic sleep. So I think that's going to bed, then waking up for a period of time, and then going back to bed for a second round, which interestingly, with small children, feels like that's the norm anyway. But am I right in saying that?
Yeah, I think so. So, I mean, the reason that we have this kind of day-night pattern of sleep is really about our kind of activities that we do. So, as a species, we're very reliant on light to carry out our activities. That we're not like, a bat that can hear really well, or badger that can sniff its way around. Like we need to see to be able to do stuff. So we're very reliant on light. So our historically our patterns of behavior have been activity during the day and then sleeping at night. But clearly there's probably a bit in the middle of the year when that works okay. But when you're in the middle of November, and the night goes on forever, like you can't reasonably sleep for that amount of time. So you're going to end up breaking that into bits. So exactly that's so the biphasic sleep pattern referred to probably going to sleep at sunset, going home to roost, and then sleeping for a period of time, and then waking, carrying out various activities. Depends where you read. Some of the places will say that Stone Age man would get up and read and things like that. But I clearly, well, didn't read anyway. But also there wouldn't be any light. So, but it'd be there is certain kind of domestic activities that need to take place, which would happen in the middle, and then you'd have a second bout of sleep until dawn, and then you get up at dawn.
Is it better to have I'm thinking about the kind of cycles of sleep. Is it better to have two distinct chunks in some ways, or is this notion of having 8 hours, a bigger, longer chunk? Is there any way of kind of measuring one versus the other, if one is preferable?
So sleep isn't one state. It's broadly divided into two. So one state of sleep has these quite brisk fluttering eye movements. So that gets called rapid eye movement sleep. And then the other type of sleep doesn't have these eye movements. And so creatively, that's been called non-rapid eye movement sleep. And non-REM is further subdivided into three. So you have non-REM one, which is really light sleep. This is the kind of sleep that you get during Netflix if you're not paying attention. Uh, and then non-REM 2 is still considered light sleep, but a little bit deeper. And then non-REM 3, that's your really deep restorative sleep that you need to get in order to feel properly refreshed in the morning. So you tend to go into sleep at non-REM 1, go through non-REM 2, go deeper, then have your really deep sleep, and work your way back out towards the surface, so to speak. And then you have your bout of REM, and then that is a sleep cycle. So that on average is about 90 minutes. And so when you wake in the night naturally, you usually wake at the end of a sleep cycle. So we actually always wake after a sleep cycle, but we usually go straight back into another one. When people have this kind of fragmented sleep, it's usually coming at the end of a sleep cycle. So whether you'd naturally have all your sleep cycles in one block, or whether you kind of break that up, I think probably depends on your personal preference, and probably depends a bit on what your kind of cultural expectations are of you. That if you're meant to be up because work starts early and finishes late, for example, then then you're going to have fewer cycles, and you might have a sleep at midday like a siesta. So I think that's what would govern that. Where I think it comes in quite relevant is when people naturally wake in the night, and people sometimes try and force all of their sleep at night, because actually for some people it is just natural to kind of wake a bit in the night. But when you try and fix a problem that isn't necessarily there, you know, really are rolling a boulder up a hill, or square peg round hole, that kind of thing, that actually it is okay to sleep in two bits if that's how it suits you.
That's really interesting. I'm certainly aware of waking up at the wrong time of my sleep cycle as well. If you're awoken by a screaming baby down the corridor, sometimes that feeling of like, oh, okay, I'll just go and sort this out. Whereas other times it can be like, oh God, what's going on? Where am I?
Especially when you
Nice.
think, is it a nightmare? No, it is actually,
Yeah,
I am awake. It is
I'm awake. I had some friends staying this weekend, and we had some lovely dinners. But on Friday night, I remember him asking me for an espresso after dinner. This is quite late on, so this was at the end of dinner, and I thought, wow, that's very, in some ways, that's it's very Italian. What a cultured man. But then I remember debating, like, are you just shooting yourself in the foot here? Is this the death knell for a good night's sleep? And I guess that nicely kind of takes me on to, I wanted to ask you about what are the most kind of common things, because I think most people understand a bit of sleep hygiene, but what are the most common things that, or most significant things that people are still doing wrong?
So certainly on the caffeine front, it's a really good question, and it's one that does get kicked up a lot. Caffeine postpones sleepiness. That's why we like it, because it makes us feel alert. And the way it works is one of the systems that controls our sleep is called the adenosine sleep drive. So whenever you're awake, your body makes adenosine. The adenosine accumulates, and the more adenosine you have, the more sleepy you feel. And the only thing that can get rid of adenosine is sleep. So it's basically this idea that the longer you're awake, the more sleepy you feel. And so caffeine works by blocking adenosine temporarily. So you get this temporary postponement of tiredness. But it's really individual the way it affects you. So I have a colleague who won't drink coffee after midday because they find that when they're in bed at night, they're just pumped and can't sleep. Me, on the other hand, I'm actually drinking coffee now. It is 20 past 8. Um,
Wow.
and I drink it because I like it, and because it doesn't really make that much difference to my sleep. So this is one of the big points about things like sleep hygiene, is that they're not really hard and fast rules. There's a lot of flex in them, and it affects people differently. So that's always, whenever I talk about sleep hygiene, it's always like a really key point. But definitely, if you drink a lot of caffeine throughout the day, that it can accumulate, and the speed with which you break that down does vary, and it gets longer as you get older. But certainly, if you're chugging a lot throughout the day and you find your sleep isn't very good, then it might be something to address. And the other thing is, actually, there's loads of things with caffeine. So the one that got me was decaf. Did you know that decaf should be called less caff, really, rather than decaf or no caff. There's still quite a lot of caffeine in there, and green tea as well. That I think is missold to a lot of people who are trying to find a caffeine alternative.
Yeah, I did know that, but that was only a very recent discovery, and that was wondering why I was still feeling quite jittery after quite a few decafs. It's interesting, that concept of caffeine, because as you say, I think everybody does respond to things slightly differently. Now, I hear a lot about people saying we're going to have a caffeine sleep, and that concept of chugging a double espresso, sort of banking on the fact that it takes a little bit of time to take effect. So you get a little bit of a nap, and then you wake up ready and wired and focused. Is there any truth behind that?
That works a
Yeah,
dream.
the Nappuccino. Yeah, do you find it works?
I've been doing that since, well, when I was doing surgical training, and I was just constantly running on fumes. But I'd find that, yeah, going to the mess with a hot coffee, by the time I'd finished drinking the coffee, I was pretty much asleep. And then I'd wake up 15 minutes later, caffeine pumping around my body and fully ready to go. But that's very anecdotal. Yeah.
No, it's definitely a thing. So napping, you should only do for maximum 20 minutes. And the reason, as you mentioned earlier, if you wake up from the wrong state of sleep, that it can be really tough. So if you sleep beyond 20 minutes, you risk getting into deep sleep, that really deep non-REM 3. And actually waking up from that point, it's quite tough to go from the deepest state of sleep that you can be in to awake in one step. It's just too much. And you wake up and you feel like a zombie, and you can't think. It's called sleep inertia. And so if you think about all the things you want to get from a nap, so you want to get this kind of pep up and alertness, this real perk to your day. If you wake up and you feel like a zombie for an hour, that's the exact opposite of what you wanted. So that's why you should always limit it to 20 minutes. And you're right, caffeine takes 20 minutes to work. So you can get the two to work hand in hand.
Is there anything else that in your practice or in the clinic that you see time and time again, like kind of quick wins or significant blunders that people are doing that's self-sabotaging their sleep?
One thing that you find quite often is, especially with hybrid working, is that when you have that flexibility with your hours, it's very easy to be working quite late, and it's quite easy to attempt to go from work to sleep in one stride. But your brain doesn't really work like that. Your brain does need to just kind of wind down just a little bit, and you don't need a really developed and really kind of coordinated wind down routine. You don't have to be very purposeful, but sometimes you just need a bit of time, literally just chilling, not doing anything. So it's worth building that in. So that's an investment in your sleep, rather than sometimes people think I need to get into bed straight away so I can sleep as much as I can. But actually, if you just take a bit of time, half an hour, just wind down a bit, then that's something that can make quite a difference in this busy hybrid world. And another thing I'd say is that when people start to struggle with their sleep, they often respond by extending their time in bed. So if you think, "Oh, I've got to get up at 6 and I need 7 hours of sleep, but it takes me 2 hours to get to sleep," then you get into bed 2 hours earlier than you really need to. But what that does is, one, lying in bed awake is just really irritating. And when you get irritated, that actually stops you from sleeping. So actually either shortening your time of bed, either going the other way and actually spending less time in bed, that will actually help more if you're struggling with your sleep. But also, aside from getting frustrated, is that it starts to change what the bed means. So interestingly, the way that you're triggered to fall asleep is actually through the association of the bed meaning sleep. So sleep isn't something that we can control directly, but it tends to be triggered because when we are babies, we're sleepy, we get put in bed. If you're a toddler, you're sleepy, you get put in bed. So you develop this very strong link between the bed meaning sleep. To the point where if you talk about the bed with people, some people will actually start yawning because it means so much. It's that strong an effect. But what happens when you're not sleeping well is that you start spending such a long time in bed awake, trying to sleep, getting annoyed that you can't sleep, that the bed starts to change what it means. And this is why, and everyone experiences this to an extent, that if you're very sleep deprived, you find that you'll nod off in front of the TV, but then when you get into bed, like something happens and your mind's just off and it's racing and you're worrying and you're thinking about tomorrow and how you're going to cope with the sleep deprivation. It stops you from sleeping. And that's what's happened, is that the bed's changed what it means. And so that's something that it's always good to nip that in the bud. So if you find that you're not sleeping, don't extend your time in bed. Actually, if you push it the other way, it sounds completely counterintuitive, but it can fix an awful lot of sleep problems.
Does that relate to the concept of talk to people about CBTI, this kind of cognitive behavioral therapy for insomnia, where I mean, it sounds horrendously brutal, to be honest, but the idea of actually, if you work back from the time that you want to wake up, and then work out how many hours you're sleeping, and then you're only allowed to sleep in that window. Is that something that you recommend? Is that something that you use yourself?
Yeah, so CBTI, cognitive behavioral therapy for insomnia, is the gold standard treatment for insomnia. And it because the perpetuating factors of insomnia relate to actions and thoughts generally. So cognitive behavioral therapy really hits the nail on the head. And one of the key drivers is this idea of spending far too much time in bed. And so one of the components of CBTI, because there are several, one of them is called sleep restriction. And really, it's not really sleep restriction, it's actually just restricting your time in bed. But you tend to, I sometimes call it the nuclear option, which patients don't always like. But exactly that. You find your rise time, you anchor that, so that's set in stone, whether it's, say it's 7 a.m. But if you're getting into bed at 10 and you're having, fragmented sleep, a total sleep time of say 5 hours, you would then be getting into bed 5 hours back from your rise time. So that would be 2 in the morning, which is clearly quite tough. And you can see how that would pan out with your imagination that, you do day one, you probably don't sleep that well. You wake up set in stone, 7 a.m. rise time, stay up all day until you get into bed again at 2 a.m. Probably quite wired by this point, probably don't sleep very well. Up at 7, up all day, back into bed again the third night at 2 a.m. But you probably find that about this time, you're so tired that you get into bed, you fall asleep straight away, you sleep through till 7, and you start to build in this consolidated block. And once you start learning how to sleep properly, then you work that bedtime back a bit in increments. But it's often quite underwhelming the amount that you actually move that bedtime back because your quality of your sleep changes completely. This idea of sleep architecture, so the states of sleep that you experience. So you tend to have a lot more deep sleep. So you often don't have to move that bedtime back because sleep has this quality rather than a quantity. But actually what you're trying to achieve with sleep restriction is you are trying to drive up this sleep drive. And so you have to accept that you are going to feel extremely sleep deprived in the first few days. So that is part of it. And the problem is that most of the evidence for CBTI, the best evidence, is actually for this particular intervention. However, it is also one of the most difficult ones to do. And for a lot of people, they need to use annual leave, things like, if you're a single parent and you have to get your kids to school, you have to work. It's not really feasible to have that degree of sleep deprivation. So it is effective, but it's one of these things where research has to meet the real world, and you have to sometimes meet in the middle with that time. And there's another similar technique called sleep compression, where you come in from the other end and you just shorten the time in bed by an hour, 2 hours, to just pump up the desire for sleep a bit, but not hitting the nuclear button. And so we tend to do more of that just because most of our clients tend to be working.
I think the mention of sleep architecture segues nicely to my next question. I'm very keen to ask about sleeping tablets. And the reason for that, I mean, again, get asked about this a lot, particularly in clinical practice. We get a lot of people coming in and say, "Can't sleep. Can I have some sleeping tablets?" And reflecting on this, there are a couple of things that I've said to patients that I've been told by people, and it's sort of become fact in my mind. But I'm interested to ask you, though, a couple of those. So the first one would be that yes, sleeping tablets sometimes will give them to reset the sleep cycle. So this feeling of giving someone maybe 3-4 days of sleeping tablets, take them every night, it gets them back into the rhythm of sleeping, and then they're able to sleep better. And then the second side of that, probably looking at this from the polar opposite, is saying actually sleeping tablets are not the way forward here because, yes, they may knock you out, but they don't improve the quality of your sleep. So you can wake up feeling very groggy and actually still as tired as if you hadn't slept at all. Am I way off the mark with those? And what are your thoughts about sleeping tablets overall?
Yeah, no, you're not off the mark there at all. No, it's not quite the solution that people would like it to be. And I mean, we're a sensible and straightforward species, and I think we like simple answers where they exist. And I think we like the idea of a sleeping tablet if it could just get your sleep back on track. But it's not, unfortunately, it comes with a bit of a cost. So part of it is, yes, the quality of your sleep has changed. So your sleep architecture changes. So you don't get all of the states of sleep that you would benefit from. Secondly, they are slightly misnamed because they don't really give you sleep. What they give you is they're global brain sedatives. And from that sedated state, sleep is easy to come by. So, but as you're sedating the whole brain, you do have a bit of there's impact on your breathing when you're sleeping. If you wake up in the night because you need a pee, people fall, and that really does happen. But there is a place for it, and part of the place for it is, I think, when people are going through an acute stress, a bereavement, a divorce, and they're stressed, and so they're not sleeping. There is what you call this bidirectional relationship between your sleep and mental health. That while we've known for ages that certain mental health conditions will impact your sleep, it actually works the other way around as well. And your lack of sleep will impact your mental health and your ability to be resilient in the face of stress. And so you can see how these cycles can just really gather momentum quite early on. And so actually giving someone a sleeping tablet so they can sleep in that acute insomnia can be really helpful, as you say, just resetting things a little bit. And the other thing is that with sleep, we don't have direct control over it. We have a lot of indirect control, but you can't control it directly. And I think when your sleep is deteriorating, you often feel like this is a situation that's rapidly getting out of hand, and you're not in control of it. So sleeping tablet, even if you don't use it, gives you that kind of power over your sleep, that perception of control, which is real control. But it means that if things get to crisis point, you know that you can take a sleeping tablet, which I think just brings things down just a touch. So that's for sedating sleeping tablets, which are the common ones. So that's like Zopiclone and various other drugs that begin with Z, and there's various other benzodiazepines like temazepam. There are other ones like melatonin, which is a sleeping tablet that is licensed in the over 55s for a trial of 13 weeks, which is an unusual number to pick. It's quite difficult to prescribe in most areas. While this one is considered a sort of milder cousin of the other sleeping tablets, there isn't actually very much evidence that it's that effective, even in the over 55s. But what's quite interesting is that whenever you start anyone on melatonin, they'll very frequently report their sleep gets better. I was actually talking to someone the other day, is this really the placebo effect? Because one of the perpetuators of insomnia is this idea of sleep effort, and that when your sleep is deteriorating, after a time you'll start to think, I need to do something about getting my sleep back on track. But after that, it swings to this thing called sleep effort, and you're very purposefully trying to get your sleep better. If you are someone with insomnia, you say, well, what have you tried to get your sleep back on track? Or how do you try and sleep better? There's normally like a sharp indrawing of breath, and then they'll talk about, 45 minutes of yoga they do before bed, then 20 minutes on the Shakti mat, a hot shower, chamomile tea, lavender butter for their feet, and then some breath work. And then they'll get into bed. And it's not like these things can't help your sleep, but when you approach it in a very purposeful way and a very intentional way, it just gathers more expectation and anticipation about sleep, drives up stress and worry about the subject, and actually stops you from sleeping. But despite all this, like it is quite difficult to just say stop trying to sleep. Because what is sleep anyway? It's not exactly a concrete concept. And so what's trying to sleep, and then what's not trying to sleep? These aren't things that I don't think we necessarily understand that well. And so a sleeping tablet like melatonin, which is fairly inert, can be this back door into actually truly letting go of sleep effort. And so people often find that once they start on melatonin, they actually start sleeping better because they're getting out of their own way and they're outsourcing effort to this tablet.
Interesting. That's really interesting. I just want to touch on that because that concept of sleep effort really resonates with me when previously doing shift work, which I thankfully no longer do. I just remember having just tossing and turning and being like, I need to sleep now. I need to be functioning for my night shift that's coming around, and just looking at the clock. And the more and more I thought about it, the worse it would get, which I'm sure a lot of people suffering with insomnia can really appreciate and resonate with as well. You just mentioned about the treatment for acute insomnia and how it might differ for those with chronic insomnia. And I became aware of a new medication, or it was a new medication to me anyway, by one of my patients who was suffering with chronic insomnia and had tried everything under the sun, seemingly to make it better. But she actually kind of contacted me saying, I've heard of this new medication called, now I'm probably going to butcher it, but called daridorexant.
That's it, daridorexant. Yeah.
Daridorexant. Now, are you able to give a summary of how this might work and how it differs to the previous ones you mentioned?
Yeah. So this is the new kid on the block, and it is very distinct to the sedating sleeping tablets. So as I said earlier, while the old-fashioned sleeping tablets were just global brain sedatives, Daridorexant is very different, and it works on what often gets called the sleep-wake switch. So there's various systems within your brain, some of which promote sleep and some promote wake. And so this works on the orexin system. So the orexin system, I guess, promotes wake. This is actually the system that plays up in narcolepsy. So if you know narcolepsy, this is an issue where you just have a very kind of sensitive sleep-wake trigger. So you find you get wake phenomena intruding into sleep. So essentially you wake up, but you also get sleep phenomena intruding into wake. Um, so you get sleep attacks for one, but you also get, for example, one of these sleep paralysis is one that you often get, because that's a feature of vivid REM dreaming sleep that your body's paralyzed. So that comes on when you're awake. So this is the system, and so the drug daridorexant is called a dual orexin receptor antagonist, and it shortens your time to persistent sleep, which is obviously very good. It reduces your overnight wakenings and improves your total sleep time. It's licensed for up to a year, and it tends to take effect from about 3 months of treatment. And it's good because it doesn't have these side effects that you find. So you don't get that respiratory depression, you don't get dependency or dose escalation. You don't get rebound insomnia. So one of the issues when you stop Zopiclone, if ever you've tried to do that with any patients in general practice, is that the insomnia bounces back and is much more aggressive than it was before. Whereas you don't tend to get that with daridorexant. So it's licensed for people who have either tried CBT for insomnia and it hasn't worked, or CBT for insomnia isn't available. So it still acknowledges that CBT for insomnia is still the gold standard. It's still the best treatment for those who don't respond, because not everyone responds. But if you don't, then daridorexant can be an option for you.
I get people who swear by valerian root, I think.
And magnesium butter. So rubbing that on feet. Someone mentioned that on the weekend as well.
Okay, magnesium butter. That I have not come across. So I don't know when valerian was. It sounds like it's been around for a long time.
It sounds like it's from Game of Thrones, right?
Lord of the Rings.
Yeah. Oh, yeah. I wasn't going to say it, but I think that's why I think it's been around for a long time. There's no evidence. But evidence is not. I don't want to be sort of unscientific about it, but I guess what we've realised about healthcare in the last, I suppose, much more in the last 10 years, is that we're actually all very different. And population studies don't necessarily elicit the individualities that we get in the population. Now, I'm not trying to dance around the fact there's no evidence, but it wouldn't surprise me if some people do find some soporific effect of valerian that tips the balance in their favour for sleep. You obviously got to weigh that up with this whole idea, as I mentioned earlier, about this placebo and this outsourcing of effort to something else. So how you tangle with that with a randomized control trial, I don't know how you do that, but it wouldn't surprise me massively. And it's the same with things like, like magnesium in its butter form or otherwise. I don't really feel like there's necessarily harm in it. The only problem I think is when, as a supplement, it's presented as a solution. So it ain't going to fix your insomnia. It's just not. It might help you sleep a bit if your sleep's a bit crummy. But also, a lot of these supplements are very expensive, and there is, the stuff that I think you would have to call a bit of a pork pie that goes on the front of the box. And I think that's where the issue is, that a lot of people who don't sleep, I mean, because you're not just dealing with people who are a bit tired. You're often talking to people who, they might have had awful things go on in their mental health, and they feel that they're in that spiral of their mental health impacting their sleep, and their sleep impacting their mental health. And they do feel desperate. And I think it's naughty, I think, to present a very expensive supplement as something that will fix your problems when probably doesn't. What's really interesting about sleeping tablets was, with all the old sleeping tablets, what they looked at in the research was actually how long it takes you to fall asleep and how long you sleep for, overnight wakenings, which is interesting because with insomnia, while the word means you can't sleep, people don't often care about the fact they don't sleep. What they care about is that daytime impact. They talk about insomnia being a 24-hour condition, but it's actually that daytime fatigue, that lack of concentration, that low mood, that anxiety. That's what primarily drives people to seek help rather than not sleeping. And so whether CBD will impact that, I don't know. I'm sure it will help you nod off quicker, but will it actually change your well-being? I'm not sure.
I had a Fitbit probably going back about 7 or 8 years, and when I got it, I remember getting quite obsessed with looking at what the Fitbit thought of my sleep. I remember thinking, God, this is quite a simplistic bit of kit. How does it know how well I slept? And I never kind of felt it was congruous with whether or not I was actually feeling tired or not. But I'm aware that these wearable technology is becoming much more ubiquitous now, and much bigger numbers of people wearing things like this, Apple Watches, Fitbit, etc., or even these Whoop devices now. And I'm just wondering, you talked about kind of sleep anxiety and the effort around sleep. And do you think, are these devices helpful in any way, or is this creating this culture of just worrying or overthinking how much we're sleeping, and actually as a detriment to the quality of our sleep?
Yeah, really good question. So what wearable tech has done for sleep that's good is that it's driven it up the agenda, because sleep is not a concrete concept. I don't know if people really understand how to approach sleep. But certainly people don't necessarily feel the impact that sleep has on their life. And I think when you look at your Garmin app or your Whoop app or whatever, and it's got sleep metrics, you think, well, sleep must clearly be important. So it's pushed it up the agenda in a way that I don't think anyone's really managed to do. So that is really good, and I wouldn't want to undervalue that. Um, in terms of the metrics it produces, they're a bit of a mixed bag. So there's one called total sleep time, which is used in sleep labs. That's a solid concept. And that's pretty accurate, actually, when you measure it against what we would call the gold standard, which is a polysomnogram, which is the electrodes on your head and various other kit. Um, it makes the assumption that if you're not moving and it's dark and your heart rate's dropped a bit, it's probably a few other bits, but it makes the assumption that you're probably asleep, which is probably about right. And so that matches up. But it's the sleep staging when it says that you've had X% of REM or deep sleep that I think the best ones I think are about 50% accurate when you compare it to gold standard, which is just way off what you need to make any conclusions. The other thing is that they do produce this thing called the sleep score, which I think is referred to as a black box algorithm. So there is some maths that go into it, but they don't tell you what it is. So it's very difficult to verify, like whether it is. But certainly, this is kind of a concept I find with stress as well. That these are complex things, and using stress as an example, there's a real richness and depth to someone's stress, like how it stresses them out. But it still is quite hard to understand. And I think it's nice to just give yourself a number. So when you get these things like heart rate variability and whatnot, like I'm not sure whether that really captures stress in a way that means you can fix the problem. And I think it's the same with sleep, that it's nice to give sleep a number, make it nice and simple, but it just doesn't quite match up to reality. Um, so, and again, it does invite you to obsess over it if you're a sort of a data orientated person. And you're absolutely right that if you're on the fence with, maybe paying a bit too much attention to sleep and being a bit vulnerable to sleep effort, if you give someone the means to be meticulous and overly thoughtful about their sleep, then you can cause problems. It's actually got a name. It's called orthosomnia. Um, yeah, so that you can upset the apple cart by thinking too much about it.
That's really interesting, David. Thank you. We've taken a lot of your time. So last question from me. I just wanted to ask about, and alluded to it at the start of the show, but this concept of 8 hours being gold standard. Am I right in thinking that's been slightly challenged recently? And actually the feeling is that your requirements vary person to person or depend on your age. So I guess to probably oversimplify the question, how long should we be sleeping for?
That's a really important question. 8 hours is more of an average, so across a population, but it absolutely varies. So between 7 and 9 is probably most people, but you do get people who are less than 7. Margaret Thatcher, she said she needed something like 4, but then there's also a lot of photos of her sleeping in meetings. So I think she might not be quite on that one. To 9, sometimes 10 hours. Like some people do just need to sleep more. But again, this idea, like sleep does have a quality. And so, Matt, with young children, like you must feel like some days, like, how are you alive if you've slept for 4 hours? But it's because your sleep does change, it is adaptable, so it does respond a bit.
Just on that as well, is there a sleep deficit? I.e., if you're someone who needs 8 hours typically, and then you go through hellish week of work, fortnight of work, where you're getting 4 or 5 hours a night, is there then this kind of backlog that you can help with, that you can rectify in the ensuing weeks? Or is that just it's the books are cleared and that's you've aged your body in that time, you can't do much about it?
There is sleep debt is a thing, like it is a concept, but again, it doesn't. it's still kind of this one-to-one currency idea that it tends to see it all in terms of time. But if you can imagine, if you had a job where you never slept, like say you needed 7 hours, but you only ever slept 5.5, and so there was constantly that hour and a half that you're missing every night. You're not going to have to make that all up at some point to feel not sleepy, because your sleep, as I said, like your sleep, the kind of the character, the architecture of your sleep will change, and so you will mop that up to an extent. But yeah, no, you do have to pay the price sometimes, and you find this with people who, because of their busy work or shift work, that they then sleep loads at the weekend to get catch up sleep, which again, like it's not a problem unless it's a problem for you. Some sleep clinics get their knickers in a twist about it, but it's not really an issue if it doesn't bother you. But it's probably not a pattern of sleep that more consistent patterns tend to be better and more robust and more resilient.
That's really nice. That's a good summary. And I like the way you've emphasized throughout this interview that it's very personal, isn't it? It's very person specific. The reasons why people have poor sleep or good sleep varies massively, and it's not a one brush for everyone. What I will try and press you on though, and try and put you on the spot with, is giving some tips for the general public. Are there any kind of golden tips that you can say these are absolute musts? These are great tips.
Yeah, there's some good practice, definitely. So, and some of them sound a bit silly. So one is don't go to bed if you're not feeling sleepy. So if you get into bed, you're not feeling sleepy, you're unlikely to fall asleep. Sounds mad, but actually everyone used to go to bed at 10:30 when the news finished. You wouldn't necessarily sleep. That's less of a thing now in the digital age, but if you don't feel sleepy, just feel empowered to stay up a bit later. It's not all about, having the same rigid bedtime. So that's one thing I'd say. Second bit is when you can't sleep, you naturally focus on the night. But actually, if you shift your focus to the day and carry out activities that reinforce the wake phase of this circadian rhythm, this thing that governs our sleep, that actually your sleep phase will arrive more naturally at night. So getting outside, again, hybrid working, it's so easy to find that it's Thursday and you've not been outside. But get outside for a walk, brisk walk in the morning, really can make a difference. And probably the third thing that I'd say is that if you can't sleep, either because you've got into bed and your mind's still on work, or you wake up in the night and you're thinking about something, is just give yourself a break and just get out of bed. Don't lie in bed um, in the dark with nothing else to distract your thoughts that get sucked into this negative vortex. So just get out of bed and find something. Find the cat, give the cat a hard time. Go read a book. Watch TV. There's no rules against TV. You can watch TV, but don't lie in bed trying to sleep, because you'll probably find it doesn't work.
Thanks, David. I'm aware that we've also not really linked you in here to explain some of the brilliant stuff you do in terms of the diagnosis of people who have specific sleep conditions. For example, those with obstructive sleep apnea, and how game-changing it can be for them to get a diagnosis and then the appropriate treatment. Do you mind just outlining some of those conditions for us?
Yeah, absolutely. So obstructive sleep apnea is this it's a very common sleep disorder, usually associated with snoring, where your upper airway repeatedly closes when you sleep. So basically holds open your upper airway and muscles. But as you sleep, all your muscles relax. And so for some people, that it just relaxes so much that the airway closes. So as you drop into those deep states of sleep that you need in order to feel refreshed in the morning, you find your airway close, you get this period of not breathing. That's the apnea. And then your body has to basically pull you back to either a shallower state of sleep or completely awake. So your airway muscles regain their tone, pull open your airway, and you can breathe again. And so what this leads to is really, really poor quality fragmented sleep. So you can sleep for 10 hours, but it's such poor quality that you wake up feeling unrefreshed. You fall asleep at the wheel, which is the big risk. But it's linked with loads of cardiovascular and metabolic risk, and depression in a lot of cases. So it's a condition that makes a huge impact on your health and well-being. Um, but it's a treatable condition, and the really challenging statistic that you come across is that 85% of people with obstructive sleep apnea are undiagnosed. So they don't know that they've got it. And part of that is because a lot of it occurs during sleep when you're unconscious. If you live by yourself, you don't necessarily know that you snore or have these episodes of stopping breathing. So you often don't come to light. Also these conditions, they can creep in very slowly, and then you just feel that this is how it is for you. This is what life's like. And you don't necessarily know that something can be fixed. So it's a bit of a sad condition that the diagnosis is straightforward. So we diagnose there's these they're watch light devices. They're different to wearable tech. But they have this socket that you put your finger in and a chest sensor. You wear it for one night, and it just collects very detailed information on your sleep and various other cardiovascular activity as you're sleeping. But it's a very solid diagnosis of sleep apnea. And then once you have that diagnosis, you can access the treatment. And like lots of things in medicine, we break treatment into lifestyle factors. So sleep apnea is more common if you're carrying a bit of extra weight. So losing weight can help, and that's very interesting with the weight loss injections. There's a lot of evidence emerging on the role of that in the management of sleep apnea. And also, if you smoke or if you have airway allergies, that treating those properly and stopping smoking can really help with sleep apnea. Other things you can do is you can get these dental devices, which are like sports gum shields that just have a section for your lower teeth that just bring the lower jaw forward just a touch, like millimeters, that just creates a bit of extra space at the back of the tongue, so that airflow can just be slightly straight forwards, and that can help a lot in sleep apnea. But the gold standard is this thing called CPAP, continuous positive airway pressure, which is this. You basically have this pump that looks a bit like an alarm clock that sits on your bedside table, and it just blows air at a low pressure through a tube to a mask that sits either over your nose or over your mouth and nose, and just holds your airway open, just gently so it doesn't collapse. And they all sound like quite unusual treatments. And you think, how would anyone ever tolerate that? But if you've got someone who really hasn't slept properly for a decade, who is looking like they've got dementia because they have so much cognitive impairment from this lack of sleep, that once you stick them on the good treatment, that they absolutely love it. Sometimes there are teething problems, but for a lot of patients, they absolutely love the stream because actually, they've got this brisk restoration of sleep, and the quality of life can dramatically improve. And that's not to say there aren't some people who do struggle with it. There are. But this sometimes people think that it's a treatment that they wouldn't get on with, and so they don't pursue treatment. But actually, it really can be life changing.
It's really something that I should get checked for. My wife's constantly telling me I sound like a tractor every night.
It's horrendous, David, honestly. Like, I've shared a tent with Matt. I've said this on a previous episode, but it's just brutal. I mean, honestly, I don't know how your wife sleeps at all, Matt.
I should get tested. I think actually she sleeps better now. I think she's kind of used to it. When we first started dating, I just woke up to see her staring back into me with wide eyes, like, "You don't look like a snorer. How is this possible?" But I think now she's just used to it. It's almost like white noise.
It's a tough one to deal with. Yeah, definitely. So we have a lot of people in the clinic who they don't go on holiday because they sleep in separate rooms because the snoring is so loud. So they don't go on holiday because they can't afford 2 separate hotel rooms. So there's all the added perks of fixing someone's sleep apnea, is that they can actually go on holiday again because
Wow.
you can get into one room without the tractor sound.
David, where can our listeners find out more from you or hear more from you?
So you can come to our website, which is www.TheBetterSleepClinic.co.uk, and you could follow us on Instagram if you're into that. We do have a few videos and other content that comes out on there.
Brilliant, fantastic. All right, well, thank you so much for your time. I will just say a quick thank you to those who are sending in questions and tips for future topics. Mike and I have been appreciating that a lot recently. But yeah, thank you so much, David, and really appreciate getting that rundown. And I'll send you an email about hopefully getting myself tested in the near future.
Thanks for having me on.